Hello, hi everyone. The topic of today's lectures is dental implants. The learning outcomes expected are should be able to define what is an implant and its clinical implications. You should be able to classify the various type of dental implants used in dentistry over the years, identify the various components of dental implants, define what is osseointegration in the concept, and select appropriate patients for treatment. A dental implant is an artificial dental root that is surgically inserted into the jawbone and that can be used by dentists as a platform for prosthesis. So here in the picture you can see this is a dental implant. This is a root form dental implant, and for additional information this is a bone level implant that is placed in the bone or the edentulous area, mimicking the root of the missing teeth. Now coming to the various components of dental implants. The dental implant body itself is known as the fixture, and over the fixture we have the first stage cover screw. Then we have something called as one second, yeah. Then we have something called as a healing collar or a healing abutment, which is placed at the second stage surgery usually. That is at the first stage surgery the implant is placed, the cover screw is placed on top of the implant, and the flap is closed. During the second stage surgery, that is revision surgery, the flap is exposed and then the healing collar or the healing abutment is placed. Once the healing takes place, that is healing abutment is placed to create a gingival profile or the gingival emergence. And once the peri-implant tissues have healed, then the next process is taking an impression. Impressions are made using a closed tray or a direct tray impression transfer, open tray impression transfer. So this is a closed tray impression transfer, this is an open tray impression transfer, and below here we see various type of abutments. That is, this is a stock abutment, this is abutment for a ball attachment for overdenture, this is a multi-unit abutment also known as MUAs. Okay, this is an implant analog which is attached to the impression transfer once the impression is taken and the cast is poured. Okay, so here we see this is a bone level root form and the endoosseous implant, and this is a crown. This is a screw retained crown which is placed using an abutment screw directly anchored inside the implant body. Okay, the implant may have a connection type which may be internal hex or an external hex. Usually nowadays almost all the implant manufacturers manufacture implants with an internal hexagonal connection. Okay, on the other hand, here we see a cement retained crown which has a separate abutment that is fixed onto the implant using again the abutment screw, and then over it the crown is cemented just like we cement the crown in case of a crown and bridge restoration. Okay, here again we can see a bone level endoosseous implants. Now these implants are different threads just like a screw drilled into a wall. Okay, and these thread diameters and the thread distance vary depending upon the design and the manufacturer. Now here we can see a healing collar which is placed on the implant after the second stage surgery. This is an impression transfer used to take the impression for the crown, and this is an abutment onto which the crown is cemented in case of a cement retained crown. So this is the abutment and this is the crown over it. Okay, now coming to the multi-unit abutments, I just want to briefly tell you what multi-unit abutments are. Here we can see multi-unit abutments. They may be straight multi-unit abutments or MUAs, or they may be angled. Now angulation may vary from 0 degree as a straight abutment to up to 55 degrees. Okay, depending upon the angulation of the implant. So more angled the implant is placed in the bore, a more angled multi-unit abutment may be used to make it parallel to the other implants. So here we see a multi-unit abutment. One screw is goes directly inside the implant body, and the second screw over here is used to retain the prosthesis or the bridge or the overdenture or a hybrid prosthesis on top of the implant, something like this. So this is a implant hybrid prosthesis which has a metal framework or metal substructure, and these are the multi-unit abutment. This is an angled multi-unit abutment, this is a straight multi-unit abutment, and they have separate abutment screws that anchor it to the implant in the bone, and we have second portion or the prosthetic screws which anchor the hybrid processes or the bridge or the uh, im- implant overdenture onto the multi-unit abutment. So there are two screws. One is the abutment screw which anchors the multi-unit abutment or the MUA into the implant body, and the second we have a prosthetic screw which anchors the prosthesis itself onto the multi-unit. Okay, so the divergent the implant, the more angled type of multi-unit abutment we will use something like this. These multi-unit abutments are mainly used in cases of the full arch prosthesis, that is all on 4, all on 5, all on 6, all on X type of bridges. So this we can see this is a hybrid prosthesis, implant hybrid full arch prosthesis on 6 implants, that is it is called an all in 6 prosthesis. You can see here there is a metal substructure. This metal structure may be milled out of titanium or cobalt chromium. Okay, so here is a cross section of an implant with multi-unit abutment. This is the implant with an internal connection. Now here we have connection which is known as a conical connection. Okay, and this is a multi-unit which goes into the implant, and on top of the multi-unit we have the suprastructure on which the restoration or the implant full arch bridge is uh, fixed onto it. So this is the prosthetic screw, and inside the multi-unit this is the abutment screw. Okay, so this is something maybe confusing at this moment for you guys. So coming to classification of implant, based on the type of the anchorage, the implants may be classified as submucosal, subperiosteal, transosteal, endosteal. And they based on the shape of the implant, they may be classified as blade form implant, such as a conventional blade or a vented blade design. And based on the surface texture, the implants may be either a pure machine titanium implant, or it may be acid edge surface, also known as SLA, and it may be porous, a coated surface, or it may be hydroxyapatite coated surface. So here we have the industrial implants, the most commonly used implants nowadays in the dental industry, which account for 95% of the implants. You can say here we have a subperiosteal implants in which first the flap is completely reflected, the bone is stripped of the periosteum both lingually and buccally and labially, and then a bone level impression was made initially when there was no CAT cam and no intraoral scanners, which was very difficult and cumbersome, and over that model a subperiosteal implant was fabricated in this way, and this implant was anchored to the bone using small titanium screws, and these were the abutment heads which were poking out of the implant or out of the gums on which the prosthesis was cemented. These implant involved a lot of morbidity, a lot of extensive surgery, and patient compliance was less. There's a lot of chances of infection later, and hypertrophic gingival growth, and also chance of failures and paresthesia of the inferior nerve or the lingual nerve, or the mental nerve was always there. And with this option, there would be settling or the sinking of the implant would also take place. So these implants were basically discontinued after some time. Now again there have been some emergence in the usage of subperiosteal implants, especially in cases of cancer and mucormycosis where we don't have other options to place industrial implants. Then these are the transosseous type of implants, also known as staple implants, in which the implant was placed through the cortex on the top of the alveolar crest to the bottom of the basal bone, and another plate was used to anchor these implant screws. Again, these type of implants were mainly used in the mandibular anterior region only, and for the retention of the overdentures. And these also have literally gone extinct now. Now hardly anybody uses transosteal implants except maybe in micrognathia cases, papillon leaf fever syndrome, that type of cases where there is no mandibular height involved available. This over here is a blade type of implant. As the name suggests, it looks like a horizontal blade. Now, something a bit more on the subperiosteal implants. Because of the advent of the CAT cam and the intraoral scanners and the CBCT, now we do not need to uh, do extensive surgeries to reflect the flap to take the impression. Using the CBCT, the implant is designed taking into consideration the inferior nerve, the lingual nerve, and the various anatomical considerations, and the implant is designed on an exocad software, and then it is milled or laser sintered using titanium. So these are custom implants. Nowadays they are no longer called superior implant but are called as individual custom implants for patients where there is no alveolar bone available to place endosteal implants, or in patients who have undergone trauma or radical uh, dissection to remove cancerous bones and tissues. So in such cases, these implants are then designed and then milled using titanium or laser sintered using titanium alloy. So here we have a subperiosteal implant for the mandibular full arch processes with four multi-unit titanium abutments attached to it in the design itself. And over this, once these implants are placed using titanium screws provided by the manufacturer, the overdenture or the full arch all on four type of processes. It may be a hybrid processes, it may be bridge, metal ceramic bridge that may be fabricated. Okay, so this is some other type of implants. Just like the blade implants, we also have some implants known as disc type of implant. It may be a single disc, double disc, or triple disc, which are placed by placing windows laterally from the buccal side of the bone in the mandible or in the maxilla, where bone width is very less. So these again they involve a lot of morbidity, lot of reflection of the tissues, and cutting of the bone, and there's a lot of postoperative swelling and can result in paresthesia. So these implants are also not much used. We have another category of implant which are mainly used in Europe, in Switzerland, Russia, and other European countries, also in India, also which are becoming popular because of their ease of use, are single piece or one piece cortical implants. You can see these are basically long titanium screws, polished titanium screws with aggressive threads at the tip. There may be three or four threads maximum at the tip, and these are basically bendable implants, so you don't require much bone. Even if in areas where bone is there, we can place these type of implants. Like here we see these are multi-unit single piece titanium polished base cortical implants. Here basically these threads are used to anchor the second cortex. The first cortex is the crest of the ulnar ridge, and the second cortex is considered the floor of the maxillary sinus, the vomer, the floor of the nasal fossa, and the pterygoid plate over here. Here we can see the sign implant is engaging the pterygoid plate. Over here we see the implant passing through the maxillary sinus, that is transsinus implant, and then engaging the pterygoid plate, same over here. And then these implants can be bent, they have a bendable neck, so basically after placement they can be bent to make them slightly parallel to this these implants, and can then be immediately loaded. They need to be immediately loaded in order to splint them, because they have low primary stability, since they don't have aggressive threads all over the body. They only have aggressive threads at the tip, that is engaging the second cortex. In mandible, the second cortex will be either the buccal or the labial cortex of the ulnar socket or the ulnar bone. So here again they are bent either buccolingually or mesodistally, as you can see over here, and then they are restored with a full arch metal bar with or in a hybrid process or a post-infused to metal bridge. I myself have restored many of these cases, and these cases are very technique sensitive. The case has to be finished within 72 to 98 hours, and require a lot of planning in with regards to occlusion. We have to give an anterior open bite and a lingualized type of posterior occlusion, and basically we need to use monoplane occlusion in the mandible and the uh, a prominent palatal cusp in case of a maxillary posteriors. So next, coming to osseointegration. Osseointegration, according to Brennemark, is a direct structure and functional connection between bone and the surface of the load-carrying implant. Okay, so osseointegration is of two types, that is between the implant and the bone. It may be a fibro-osseous integration, or it may be an osseointegration or the biointegration. So fibro-osseointegration, first we have soft tissue interposed between the implant and the bone, and then later on bone deposition happens, and then it becomes a biointegration, that is implant is covered by the uh, bone itself. So for this purposes implants are surface treated to encourage the growth of the new bone and to encourage a bioresponse. Okay, so initially we have fibro-osseous integration, and later we have biointegration, that is a true osseous integration with the implant, and this is what is desired. Fibro-osseous integration was seen in earlier implants that did not have any type of surface treatment, that is, they were polished or machined implant surfaces. And fibro-osseous integration does not last for a long time. Now, coming to surface treatment, so implants can be surface treated or the surface coated using different materials like hydroxyapatite, graphene, magnesium, or growth factors, and even antibiotics. Okay, so the coating may be done using different industrial processes like they we have initially earliest when Brinica started producing dental implants. Who first tested implants on rabbit tibia, these were polished implants. Then came the machined implant, that is, implant surface was machined to give a matte finish. Even these implants were made using pure titanium or titanium alloys, but they were not very encouraging because the bone integration was delayed and there was mainly fibro-osseous integration. Then came the acid etch implants, also known as SLA implants. Okay, so SLA implants encompass both of these things. That is, they are first sandblasted using silicon dioxide or silica, large grit silica, and then they are later acid etched to create microporosities to increase the surface area and the surface energy on the top of the implant surface. That's why they are called as SLA, that is sandblasted large grit and acid etch. So SLA implant, SLA coatings are the now most favored coating that are placed on the implants. Other type of coatings are we can coat the implants with magnesium, graphene, and dopamine. Graphene improves the bioresponse, it reduces inflammatory exudate, and dopamine enhances the bone deposition and reduces the inflammation. And magnesium also promotes bone growth. Hydroxyapatite results in new bone growth on the surface of the implant. So these are mainly done to uh, accelerate the bone growth around the implant to prevent fibrosis integration. Okay, moving on. So what is the difference between a teeth and an implant? It is obvious a teeth has a periodontal ligament which has various periodontal fibers, gingival fibers, various receptors like sensory receptors, mechanoreceptors, okay, proprioceptive receptors, whereas the implant is devoid of the periodontal ligament, because when you remove a teeth, you are also removing the periodontal ligament. So implants are directly also integrated to the bone. There is no ligament or a sling around the implant. Implant cannot migrate or cannot intrude or extrude. There is no proprioception in the implant, whereas the teeth have proprioception. Implants are contraindicated in growing individuals because the growth and development of the osseous structure is still not complete, and overloading or malfunctional habits can cause microstrain and microfracture of the implant or the bone itself. Okay. So, what are the indications for implant placement? Of course, the first primary indication is for aesthetics. The second is to restore the function, that is for chewing, mastication, and speech. And implants can also be used for space maintenance and stability, or to create a stable occlusion. Many implants are used in case of orthodontic anchorage to hasten the treatment, and then of course they are convenient and comfortable just like a natural tooth. Implants also help to preserve the bone because they allow the stresses or the occlusal load to be transferred to directly to the bone, so thereby preventing disuse, atrophy after tooth loss or after denture construction. Okay, so coming to various materials that are used, as I mentioned, initially implants were made of pure titanium alloy. In titanium also we have different classes of titanium alloy, titanium. So type 4 type of titanium was used for the fabrication of pure titanium implant initially, but it was later found that pure titanium was not very strong, and later various titanium alloys were used. That is the most commonly used titanium alloy Ti6AlV4. So this is a titanium alloy that is used by majority of the manufacturers for manufacturing industrial implants, which are then surface treated with either SLA, or they are plasma sprayed, or they are coated with hydroxyapatite or magnesium or graphene. Other type of implants, we have non-metallic or metal-free implants, which are now slowly gaining popularity, also known as ceramic implants, which are made of zirconia. So more about ceramic implants over here. Straumann and many other manufacturers like Lasag, Straumann, Noble, and Ceraroot have manufactured their own ceramic, that is zirconium dioxide implants. So initially these implants were available in single piece, just like the cortical implant. This is a single piece implant in which the abutment and the implant is attached, is one monoblock. Later, they Straumann started to manufacture two-piece implants like the Straumann Pure, which has a separate abutment just like a conventional titanium implant. But of course, the screw that anchors the abutment to the implant body or the crown to the implant body is still made of metal, that is a titanium screw is used, whereas the implant itself and the abutment are made of commercially pure zirconium dioxide. Okay, so here is noble pearl, another type of ceramic implant, again made of ceramic, and again the abutment is also made of the same material, which is zirconium dioxide. These type of implants are mainly used in non-stress zones like the anterior regions, especially in the mandibular anterior and the maxillary anterior regions, where the bone is very less and the gingiva is of a thin biotype that may result in gray shadowing of the under the crown if a metallic implant and metallic abutment is used. Okay, so in these cases, now these implants are very popular, and for those patients who are paranoid that they should not have any metal in their body, so we can use these implants. But of course, long-term studies are not there. Survival rate of these implants may be less as compared to titanium implants because zirconia is a very brittle material with extreme hardness, and therefore fracture can happen. Okay, so again, the abutment screw inside these implants is made of titanium only, but it does not show through outside because zirconia is a very highly opaque material. Okay, so how long do these implants actually last? Realistically, implant restorations, 90% of the implant restorations are meant to last for 10 to 15 years, beyond which anything is bonus. Okay, so this is the average lifespan for implant. They are semi-permanent solutions. Patient should not be promised that this is something which is permanent because the success of implant depends upon the proper technique, proper placement of the implant, the systemic condition, health of the patient, the oral health, how patient maintains his oral health. That is also very important in longevity of an implant restoration. Also, coming to risk factors, there are different type of risk factors that need to be considered before considering a patient for implant placement. These are basically systemic, like uncontrolled diabetes, patients on immunosuppressive medications like steroids, mycophenolate, mofetil, and other type of antihelminthic and other drugs like for use mainly for transplant patients and patients who have undertaken certain medications like chemotherapy like bisphosphonates that predisposes a patient to osteoradionecrosis. Okay, so in such cases you have to be very careful in patient selection. Proper medical evaluation needs to be done. Certain amount of time needs to elapse when patient has taken bisphosphonates before can be considered for implant placement. And there are certain tests that we need to do, that is laboratory tests that we need to do to evaluate certain markers in the patient's blood before we can consider them safe for implant placement. Local factors that may jeopardize implant placement are patient who has a history of recent radiation therapy. Of course, this can be overcome by delaying the treatment by 6 to 1 months to 1 year, and by asking the patient to undergo oxygen therapy. And patients who are chain smokers, patients with poor bone quality and bone density, patients with history of periodontal disease with the existing dentition, and patients who are known bruxers, who have parafunctional habits like bruxomania, bruxism, or any psychological things, psychological conditions that may predispose them to excessive occlusal loading. And of course, other risk factors that may mitigate or complicate the implant treatment and its prognosis is periapical lesions, endodontic lesions, or endoperio lesions in the adjacent tooth next to the implant site. If the patient has a very high smile line and unrealistic expectations of with aesthetics, and of course soft tissue biotype, this is very important in my experience. I found it the hard way that that type of soft tissue you need to have sufficient keratinized tissue all around the implant to for the longevity of the implant restoration. The however good you place an implant in a good bone, if the patient has very thin type of gingival biotype or no what you call uh, keratinized connective tissue, keratinized gingiva, then the longevity of the implant may be affected because of the thin gingival biotype. So a thick, healthy keratinized mucosa is very key in maintaining a proper hermetic seal around the implant, maintaining the blood supply of the bone, and preventing peri-implantitis. Okay, so that to the end of this lecture almost. So other now after the considering the patient, what are the contraindications in which you must not do an implant? Like I mentioned before, they are mainly systemic and local factors. So radiation therapy, any malignancies, uncontrolled periodontal disease, uncontrolled drug or alcohol use, chain smokers, patient with psychiatric disorders, patient with heart conditions or valvular prosthetic surgeries, patient who have undergone intravenous bisphosphonate therapy recently, patients on immunosuppressions, and patient who cannot maintain sufficient plaque control, or patient with diminished mental capacity. So in such cases, you must not do implants. So what other treatment options are then available? Of course, either we do no treatment, we give the patient a denture, give the patient a bridge if he has sufficient teeth to retain a bridge. Okay, or we may consider some other type of implant treatment options like giving the patient an overdenture where cleanliness can be maintained with less number of implants. Okay, treatment planning is first. We assess the patient's expectations, his complaint, his desire. We take a dental history, medical history, do a thorough external examination, and we do diagnostic imagery such as periapical radiographs, then OPGs, and then a CBCT for the arch or the jaw involved. And then we do the treatment planning and diagnosis and present the patient with the treatment plan, the time, the cost estimate, inform the patient about the all the factors involved, take proper consent, and then only we go ahead with the treatment planning, and both the parties involved are mutually binding to the agreement. So now moving on. So this is a CPCT that is used for the treatment planning, the surgical planning, and for patient education. So using CPCT, we can assess the bone density, the bone weight, bone height, the anatomical structures, any pathology, and then we can plan the implant where they need to go. We can even fabricate a surgical guide for these things for the placement of implant. Of course, not every case we can do using a surgical guide. And then brings us to the end of our lecture.